Thank you for all coming. This is a special Tuesday seminar series organized by Institute of Biomedical Engineering at Bogazici University in conjunction with Center for Life Sciences and Technologies and its industrial interface projects, İstanbul Health Industry Cluster or İSEK, İstanbul Sağlık Endüstrisi Kümelenmesi. This will be hopefully our students or faculty members and interested members from our industry, as well as from government will join us in this seminar. Today is a special seminar. We have a special guest, a very timely topic. We'll talk about this pandemic modeling, and we are all interested and motivated to hear how we can understand the spread of this pandemic, infectious diseases. Our guest is Hasan Güçlü. He's a physicist by training. He finished his undergrad degree and master's degree from Middle Eastern Technical University and followed by a PhD in physics again at Rensselaer Polytechnic Institute in New York. Then did a postdoctoral training at Los Alamos National Laboratory in US. Continued to work as an assistant professor in computational mathematics at Rochester Institute of Technology. He was later moved to work at a Department of Health Policy and Management at University of Pittsburgh before he moved to Medeniyet University, Istanbul Medeniyet University. He is working there as a professor in Biostatistics and Biomedical Informatics, also heading a program in Biological Data Science, Master of Science program. So his interest is modeling of simulation of infectious diseases. I've been get to know him due to this pandemic, when we initially have panicking everywhere. We were initially trying to get a handle where we're gonna go. And I've been following him on social media. I know he tries to keep up with the data, and he knows probably where we're heading on, and he will talk a brief, of course, in general about infectious diseases, how we model them, but hopefully we will have some time for question and answers. Thank you for coming, Professor Güçlü. Looking forward to your talk. The floor is yours.
Okay, thanks so much. Hi, everyone. Again, let me repeat my name. My name is Hasan, and thank you for the invitation. Today I will talk to you about the infectious diseases and how we model infectious diseases by using mathematical as well as computational tools. And in the COVID-19 specifics, I'll also talk about some analysis that we have been doing about the disease, about the pandemic. But it's always hard to tell where it will go. But as a modeler, this is kind of our job to really make some projections. We call it nowcasting. We don't call it predicting because we are not really predicting anything. We don't have a crystal spheres. We have some tools that we trust that might lead us the way. It doesn't tell us what is going to happen, but what might happen might be in our reach with these models. Okay, so I named the talk as contagion, since we are talking about the infectious diseases. It's always about contagion. And I'll briefly tell you about some earlier models, some new models. I'll try to be as understandable as possible. The subject itself is quite complicated, and especially if it's a pandemic. The whole world is involved, and it contains all the biology in it, all the immunology, all the computational tools, sociology, psychology. Everything is in pandemic. It's very difficult to manage a pandemic because you have to consider lots of different dimensions. I'll try to give you the computational epidemiological point of view. So this has all other implications, all other dimensions as well, including the economy and others. Okay, all right. So this is the situation as we are in right now. As of yesterday, totally in the world, global number of cases about 140 million cases. We have more than 30 million deaths, I think. Here we are in the top 7. Yeah, 7. So we are in a good place. We used to be our ranking was different before. Total number of cases in our country is about 4.3 million. And the death is around 30,000. With that, there was some problems. I'll tell you more about it when you have time. This is Johns Hopkins University's dashboard, which is quite good in giving you a summary of what's happening in the world in all countries, based on official reports, of course. They don't have sentinels to sense the data. They are relying on the WHO reports because countries report to WHO, World Health Organization, about their cases, number of tests, etc. They also use some media to collect data, but they trust on the official counts, not on the media. Otherwise, it would be a different story. Anyway, so if you look at here, this little panel on the right bottom, the pandemic started. There was a wave, and after the wave, we think it was okay, but then another one came, and we are right now in one of the worst ones. And this is something we observed before, especially the Spanish influenza during 1918 influenza pandemic. We have seen similar stories in all around the world. I'll tell you more about it. This is the situation in our country as of yesterday. We had 55,000 cases just in a day. And we found about these cases out of, I think, 320,000 tests. Just right here, yeah. So we are interested in different statistics, especially the number of cases is one thing, but it's not everything. We look at other things, we make some measurements, we make some calculations. For example, the epidemic speed, epidemic rate that we are interested in, we calculated. We also look at the positive test ratio, how many people are coming for tests and how many of them are positive. This is also an indication of how the pandemic in your country might be it was going bad or going well. Okay, so I'll, since this is a talk about infectious disease and especially COVID-19, I'll just give you a few slides about the overall, what is this disease, what's causing, etc., based on the WHO information. Okay, in Wuhan, China, in the province of Hubei in December 2019, there were some cases, unusual pneumonia cases. And the government officials were very much worried that this might be another epidemic, another infectious diseases. And they were right. They later found out the virus, which was a new virus. It was a cousin of some other viruses. We call them coronavirus family. This was one of them. It was similar to the SARS virus, but different. And later they found out that the source of the epidemic, the source of the infection was a market. It's a seafood market, but they have also some live animals very close to each other. So it's a hotbed for any infectious diseases, especially zoonotic diseases, the diseases in animals which can jump into the human societies. And it took a while for the WHO to declare this as a pandemic, as an emergency, public emergency. This happened in January 30 of 2020. And then really, even before that, actually, people were very much worried. In our country, we were also worried about the disease. We knew it would come. We knew that, and it came. Were we ready? We were kind of ready. I mean, our hospital, we cannot do anything about the hospitals in just a few months, but we were kind of ready with our measures, with our interventions, but then the story spiraled out in different ways. Okay, this is a coronavirus. It's called coronavirus because corona means crown. These protein spikes around the body, the cell body of the virus is called protein spike, and they look like a crown, so it's called coronavirus. It's from a coronavirus family. There are many other coronaviruses. In it, there's some genetic material that it's trying to duplicate, and it's protected by an envelope. It's a large group of viruses. There are many other viruses, such as SARS virus in China. We've seen this little pandemic in 2003. MERS is kind of endemic, especially in Middle East. That's why it's called Middle Eastern respiratory virus. In Saudi Arabia, first we seen it in 2012, and SARS came in 2019. It had a different name before. It was nCoV, the new coronavirus. Later, the name of the virus is now SARS CoV-2, COVID-2, then the disease it causes is called COVID-19. It's a respiratory disease, just like common cold, but it's much more severe, much more deadly. And the source of the virus, source of the disease, happened to be an animal, just like other coronaviruses. In MERS, it was a camel. In SARS, it was animals that bush meat that's being marketed in China and other countries. And for the coronavirus, the COVID-19 virus, it was thought to be a pangolin, which was bitten by most likely a bat. If you look at the genetic material, it's giving us some idea. This is what we call a spillover. So there's some disease in some society, it's an animal society. We don't have the disease. At some point, the virus tries to infect humans, especially if they are close to animals. Most of the time it fails, but when it gets success, then it might just spill over to the human society. Okay, and there are lots of different factors. The transmission is mostly through droplets, heavy droplets, but it was known that now that the small droplets, which can stay in there just for a while, might also have enough virus to infect others. Most of the transmission happens through close contact, so handshaking, hugging, kissing, talking to each other. Because when we talk, especially when we shout, when we yell, we produce lots of viruses if we are infectious. There are also some cases that through objects, through fomites, but it's considered very low probability. Most of the times, close contact is the most important way, most important route for transmission. Okay. There are just different symptoms. Just by looking at the symptoms, it's really hard to tell it's COVID-19 or another cold, common cold or flu. It's really difficult. But some fever usually accompanies the virus. Real fatigue experienced by the individuals. And there are some respiratory symptoms from cough, sore throat to shortness of breath, and very rarely skin rash. In some cases, loss of taste and smell. And this is actually sometimes, they don't heal even after you are over the disease. This is what we call long COVID or post-COVID syndrome. Okay. In severe cases, it causes pneumonia because pneumonia is just waiting. Either through a flu or some other disease, it's just waiting. When your body is weak, it just comes out. And in some cases, that's usually the number one reason for that is the pneumonia after COVID or in parallel to COVID. And it causes some other failures as well, and organ failures. Since it's using some special receptors, it's in the upper respiratory system, as well as the other parts of the organ, a little bit in heart, etc. So wherever it finds those receptors, it will go there. The incubation period was about 5-6 days. It ranged from 1 to 14 days. It's very rare to find 14 days of incubation. Incubation is the period you are exposed to virus, you have the virus, but it times to replicate for the virus. So before you become sick, it takes some time. This is what we call incubation period. Okay. 80% of the individuals usually recover without any special treatment, but the rest might have some problems, and about 5% of them had really difficult problems in the hospital. And there are some groups at risk, some conditions, obesity, diabetes, chronic respiratory disease, or being old usually is a risk factor. If you are in one of these classes, if you are infected with COVID-19 virus, then it might be a little difficult for you to really heal. Okay. All right. How do we diagnose? We use the polymerase chain reaction test, reverse transcript test, because every virus has a genetic fingerprint, and this test looks for it and finds it. And there are other tests, serology tests from blood. This is what we use when we try to see whether you had the disease before. Because when you had the disease, your body creates the antibodies in your blood. And we look for those just to see if you had COVID-19 before. There are no really treatment that fits perfectly well to this disease, since it's a new disease. We don't have a perfect antiviral for it. The antiviral we use for other diseases are usually okay. It's helping. At least it's helping you that you don't get too sick. you don't become a really heavy patient. It helps, but they are usually not perfect, like the remdesivir used in the United States and the favipiravir we have been using to treat COVID-19 in Turkey. Prevention, everybody knows about the prevention. Maybe I shouldn't really repeat it, but the covering mouth and nose, using mask, washing hands, washing properly, at least 20 seconds. Just like what they say, you sing the happy birthday song twice. Enough time. That's enough time to wash your hands properly. Social distancing, because we know that the disease is kind of airborne, but not stay in the air for a long time. But the social distancing helps a lot. These days, the air conditioning and the air quality is also a factor because some small droplets might be hanging in the air, which might have some virus, which might get sick. That's why the opening window is also a prevention method. Okay. That's kind of a combo spot. So now let's talk about the modeling and simulation. How do you simulate? How do we model this disease? Let me just give you a very short history of the outbreak. Starting with the bubonic plague in 1350s. This is actually the second bubonic plague. The first one was in the time of Justinianus in Istanbul in 500s, 6th century. Millions of people died. Even in Istanbul, millions of people died. And the bubonic plague, as you see in this map, was the #1 killer in Europe. The total population was about 100 million, and it's estimated that about 1/4 of this population, about 25 million people died. And it took some time for the disease to spread. It takes time. These different color codes represent 6 months of intervals. So in 6 months from here to here, in 6 months from here to here, etc. I can't really imagine if this happens now, since we are much more connected these days. And the epidemic, the infectious disease is always bad for cities. It's called an urban problem. It's always an urban problem. People are close to each other, so it's very easy to infect others. And there are many others. Another one is the smallpox, Czech, in Aztec, not only Aztecs, but also caused lots of people die. Maya, this Mesoamerican and South American civilizations in the 16th century. The reason for these deaths was not the Cortes, the Spanish conquistador, but the disease itself. 1850s, I'll give you another example later about cholera in London, killed lots of people. Spanish influenza killed about 20 million people, 1918-19. Russian typhus also killed about 3 million people in Russia. Smallpox was declared eradicated in 1979. This was a big public health success because there was no disease anymore. These days, the WHO and everybody else was trying to really eradicate some other diseases, especially the polio, but still polio is endemic in Nigeria and in Afghanistan. I think if the disease is eradicated there, WHO will declare that the disease is eradicated, but it's a very difficult business. And later came all other diseases. We are not, short of diseases, from AIDS to Ebola. In 1995, it came back in the 2000s. SARS, avian flu, swine flu. It doesn't end because the viruses change themselves. Viruses change their genetics and comes back as much more stronger, much more infectious, sometimes much more deadlier. Okay. So what we are trying to do is we try to create a model of reality. A simplified version of reality, just like this game. If you are familiar with this game, it's called SimCity. In SimCity, you are the mayor. Okay, so you are responsible for opening up spaces for people, for commercial activities, for living, for industry, etc. And if your city is good, then people will like it, then they will come, so your population will increase. You will make more money from the taxes, etc. But the individuals, your citizens have always, problems. So you try to solve them, from crime to fire safety to environment, etc. This is what we are doing. We don't have all these graphic artists and programmers to do this kind of animations, but we try to do something very similar. In our models, we take each individual, we let these individuals to live in their environment, in their houses, with the household members, and then they go to schools. If they are students, they go to workplaces. If they are working, if they're in the working age. If they are retired, they live in the household or they live in other facilities. And we try to create an epidemic. We make some individuals infectious, and the infection spreads from those individuals to others through contacts, etc. And we try to come up with different intervention methods, or we try to value the intervention methods, how valuable this is, how good it is. For example, during COVID-19 pandemic, we said this, the young people and children under the age of 20 will stay home. They won't leave home just maybe a few hours in a day. We really have to measure what the effect of this. Or the people over age 65, we kind of put them in the house, and we are not letting them to live. And we have to really measure this. And the modeling is a way to really come up with some methodology to measure that. It will give us an idea what might be happening. It will give us an idea what could be the new scenario, or based on your scenario, what could be the effect on the number of cases, etc. Okay. So modeling is not something new. We always model. This is what we call a mental model. In our mind, we always have a model. For example, if I'm going to the faculty of my university, I know when to leave, because I know that the traffic in Istanbul is really bad. If I leave early, I will arrive early. If I leave in some time window, it will be very difficult. Or if I wait more, then it will be easier. So this is my mental model. It's not a perfect model, but it's a good model for me. It's helping me to live properly. It's helping me to come up with good strategies, okay? And the modeling itself is just an extension of that. Our public health authorities have some good models in their mind. They know how to respond to the epidemics. They know how to respond to the other public health emergencies. In our models, either in computer or in mathematical equation, we try to mimic that. We try to create something similar so we can have more room to play with, right? Because it's not easy to experiment with public health, but in models we can experiment. We can ask, okay, what happens if I make the vaccination 30% faster, 50% faster? What happens if I just let some individuals leave the house, or if I don't let them leave? What would be the effect of this? This kind of scenario question can be answered by using modeling. It will not give you a perfect answer. It's going to give you a distribution. What might be the worst outcome or the best outcome? And based on that, you can create some public policy, public health policy. This is what it's for. Okay. And of course, we know that the model and reality is never the same thing, but we are not after that. We are not trying to mimic the real life perfectly. We cannot do that. We know that. But if I create some simplified version of reality, yeah, it will help me understand reality. It's not going to be perfect, but I don't want it to be perfect. Just like Pablo Picasso said, for art is a lie, but it helps us understand the reality. Art is a lie, but it helps us understand reality. The same thing for models. They are lies. Right? I'm just making them up, but I'm trying to make them realistic so it can be a model for reality. This is always what we have in mind in creating our models for infectious diseases. Okay, just like the Magritte's painting, it says "Ceci n'est pas une pipe." This is not a pipe. Bu bir pipo değil. Everybody knows it's not a pipe. It's a picture of a pipe, right? Just like the models. I know that it's not reality, but it just gives me an idea that what reality might be, okay? And I know that these curves are not real epidemics. I'm just creating them in my computer, but they are helping us to understand the real life situations. This figure has been used a lot. It's almost a caricature now, but it still has the essence of the public health interventions. We have a healthcare system capacity. It's constant, right? And the pandemic we are experiencing is much worse than that. But with the prevention methods, with the measures we have, with tedbirs, we try to suppress this so that it will be less than the healthcare system capacity. It will help us, because if the healthcare system capacity is full, then you won't find beds for people who are in need, right? And then the deaths will increase much more than expected. I don't want to go into details, but we have always this modeling cycle. We formulate the question, we assemble some hypotheses, we obtain some data, a number of cases and other data. We parameterize these data. We choose a model to properly model this, and then we code the model, or mathematically we solve the model, and then we get some results, we analyze those results, and based on some different methodologies, from sensitive analysis, validation to verification, we try to make our model more realistic. And this is a cycle, it just turns around and around, okay? Basically, what we are using is systems thinking. When you look at something just like the pandemic in our country, it's a complex system. So what we're trying to understand is, if I touch here, what happens? If I touch here, what happens? I'm trying to find out, I'm trying to optimize the measures. I'm trying to optimize the interventions, the prevention methods, so that I will get the best outcome, okay? What if I do this? Then how many people will have the disease? How many cases am I gonna have? If I do this, then what, etc. These kind of scenario thinking is actually a part of systems thinking. So we have to know the actions. We have to come up with good actions. We also have to know its repercussions. What can happen if I do this action, etc. Okay, and this is from a bird's eye view. This is from a public health policy view. Okay, when they look at the system, the society, they try to use different knobs, right, to change the society so that they will, follow the rules. They will wear face masks. The response to pandemic does have to contain the psychology of the individuals. If you lose it, you will lose the pandemic. Okay, the number of cases will increase for sure. Okay, this is one of the earliest models. This is a picture from a cholera outbreak in 1852 in South London. There's a doctor, we call it one of the founders of the public health or epidemiology, John Snow. John Snow was here, and he tried to come up with the reason of the disease. He went to each house one by one with the help of a local priest. He asked each household how many people died in this household, and well, lots of people were dying. So he created this map, and he put these marks on the households just to show the number of people died in that household. Okay, just based on this map and some analysis, he found out that something wrong is here. There's something here centrally. There's something. There's a problem here, and he realized that there's a pump here, tulumba, right? People get water. There is no public water system. Just this is the public water system. Just one pump, and hundreds of individuals around it just getting water from this pump. And cholera is a waterborne disease. Cholera is a waterborne disease. So the John Snow said that this was the problem. He convinced the local council to disable this pump. They disabled it, and later they realized that the number of cases, a number of deaths dropped after this. Later, some people argued that the disease was already, the number of cases was already dropping, etc. But now we believe that this intervention had an effect. Okay, this John Snow, but not this John Snow. Okay, and that's the pump still there. Okay, now let's model. Before this, we have to understand the biology behind it and the immunology of our body. Okay, here time. This is x-axis is time cyst infection. Okay, and y-axis shows some body activity. Anyway, there are two parallel lines here. One is infection status, and the other is medical status. Okay, let's look at the infection status. Now, this time 0 is the time you get the infection. You get the virus from somebody else, from a friend, from a family member. Okay, before that you are susceptible, meaning you are not sick, but you can be sick. So somebody might infect you, okay, because you don't have the immunity. You have never been vaccinated, or you never had the disease before, so you are susceptible, okay? And after you get the virus, you do not immediately get sick. You don't immediately feel sick, okay? There's a time, we call it exposed or latent period, okay? In this latent period, the virus multiplies in your body, okay? And when there is enough, then you become infectious. When there's enough virus in your body, you become infectious. From your nose, you start leaving viruses, so you can make other people sick, okay? And most of the time, most of the people, if they are healthy enough, they will recover. After some time, while they're infectious, then they recovered. After they recovered, for most of the diseases, they don't get sick again or take some time, okay? And nobody can infect them as well. This is the infection status. It's not easy to know this status, okay? But the manifestation of medical status is easier to observe, okay? In medical status, after we receive the virus, we are in incubation. Just like the exposed virus in our body, it multiplies and multiplies, right? But it takes some time for the body to create some, to show itself. So after the visible effects, we have the disease, okay? The problem here is between this time and this time, there's a period. This is what we call pre-symptomatic. These individuals have the virus and they are infectious. But they don't look like they have the disease. Okay. For COVID-19, this is about 2 days or sometimes 3 days. So for 2 days, sometimes 1 day for some people, so on average, let's say 2 days, individuals are sick, they are infectious, but they don't feel sick. This is not asymptomatic. There are some individuals, about 40%, they are asymptomatic. They are not that infectious, but still infectious. They don't feel sick or very mild symptoms for the duration of the disease. But these are pre-symptomatic. They will develop symptoms, but there's a period, 2-3 days. In pre-symptomatic period, lots of people infected others. They did not stay home. They went to school. They went to work. They had contact with others because they did not feel sick. Oh, I'm healthy. Why do I have to wear the face mask, or why do I have the social distancing if other people are not sick as well, right? Anyway, so this is the kind of the immunology and biology behind an infectious disease, and in almost all of them we have this kind of behavior. Okay, let's start with a simple model. This model is from 1928, developed for malaria, SITMA. It's called SIR model because it divides individuals in a society into 3 different compartments. It's also called compartmental model, okay? They are named SIR because they stand for susceptible individuals, infectious individuals, and recovered or removed. People who died, who lost their lives, are also in this R compartment, okay? Initially, everybody's susceptible. If this disease is not known in the area, and everybody's susceptible. So you import a case. You put that person in the infectious box, right? This person now infect others. So it will attract individuals in the S compartment into I compartment. So in time, S will decrease, I will increase, gets bigger and bigger. If you have more and more infectious, it's more likely to have the disease. It's more risk for any individual who are susceptible if there's more and more infectious individuals. And after some time, with some rate, G, these individuals in I goes to R, right? This is also called a flow. So individuals flow from S to I, wait there for a while they're infectious, and then they go to recovered, okay? This is a very simple, very simplistic model, but it helps a lot. We can write differential equations to analyze this. So the change in S, susceptibles, always decreasing. That's why it's negative. Usually, I don't show these equations to medical people, but you are engineers. I'm sure you will understand this. The change in S in this box will always be negative because it will decrease all the time. Okay, its speed of decreasing is proportional to the number of susceptibles, if there's more susceptibles, and number of infectious. If there's more infectious, more people will be infectious. Okay, will be infected. And the I compartment is fed by the S, the I infect S, and S comes into I, but also slowly people from I go to R because they recover, right? And it's here, it's decreasing and increasing term. And R will always increase because there's more and more people recover, okay? And the equation is like this, it's proportional to the number of infectious individuals. And there's some parameter in G here. This also helps us to define something we call reproduction number. We use this number, I'll have some more slides if I have time. We use this number just to show how bad the disease is. Not because it's, more people are killed, more people die, but more infectious. That also includes infectiousness, okay? This is what we call reproduction number. And here in this setting, it's proportional to B. So the B takes from people from S to I, and inversely proportional to G. So if people stay in I more, so the infectious period is longer, that means they will infect more, okay? So disease is worse in this case. That's why it's inversely proportional to G, okay? This very simple, simplistic model is sometimes very useful. This is plague cases in early 20th century in India in 1905 to 1906, about 10 months. You look at you count the number of cases, and then you see that it's very well, perfectly fit into our SIR model. These dots are real data, And the curve is coming from the equations just I showed you, okay? It almost perfectly tells you what the story is. But this is a semi-closed society. So there are no infectious coming, and the internal dynamics is different, right? But still, it helps us understand the real-life epidemic scenario. But this is our reality. It's not that simple. This is a number of cases per million people from early March 16, from the first index case to today, not today, yesterday. And we had this initial wave. After that, we said, okay, it's fine. It's summer, then we'll be okay. But we knew that it was going to come because this virus will not die in summer. It will be less active, but it will not die. It's going to be here and there, but when there's enough, human contact as well as the humidity is usually what it's the problem. It doesn't like humidity because of the pressure in the air. Then the droplets, the amount of virus they carry decrease. That's why in summer there's less disease. Okay. But later we came into the second wave around December. And there's a problem here. Counting cases and counting sick people were different. We did not know that. That's why there's a jump here. This is not real jump. It's actually something like this. But the counting the cases and the sick people changed. After this, they were the same thing. And these days, these last 3 months, we have seen a big increase. Most of the time, this kind of increase signals a change in the virus. The society cannot change that fast, but a virus is the most important actor here, playing the role of increasing the disease, because the new the variants are more infectious. New variants are more infectious. We have about 85% the UK variant B117. It's more infectious and a little bit more deadly. That's why it's replaced our older virus. Now 85%, most of the people in Turkey right now is carrying B117, the UK variant, okay? Slowly it's decreasing these days. I'll show you another graph, but I don't want to make things complicated. But these simple model SIR can be extended to make it more realistic. For example, you can just create a quarantined compartment. You can add this compartment just to show that if some people are quarantined while they're infectious, instead of going around and infecting other people, what will be the effect of that? These models actually allows us to do that. This is our model we have been working on for some time. In this case, we try to come with all the compartments, okay? We have the hospitalized, because not all infectious individuals are hospitalized. Some of them are isolated cases at home or in the hospital. At home, and some of them are not feeling well. They were hospitalized, and there's recovery all the time from hospitalized, from isolated cases at home. There is also this, some of the susceptibles might not be accessible to infectious individuals. They are at home, right? If you are home, then the risk is always decreased, because the only risk you have is your family members, household members. If they are sick, then you can get sick. But if you're outside, if you go to work, if you go to school, if you go to other places, then you are increasing your risk. Okay, we try to accommodate that by adding another compartment here. Okay, I don't want to go into details, but these models can be made more complex. But if it is too complex, then it's not going to be easy to analyze it. Okay, we don't want to make models too complicated. Sometimes models are more complicated than life. Like maybe it's not, but it looks like so. Okay. Anyway, so for Ebola, we have an even larger model, because in Ebola, the funeral, the dead body is also infectious. In other diseases, when the host died, the virus will die. But in Ebola, it takes some time for the virus to really die. That's why the funerals were also infectious. Quite many individuals at the beginning of the epidemic infected through the funeral, through the body, the dead body, because they were the ones who were dealing, disposing the bodies, okay? And more complicated mathematics around. Anyway, so let me just go ahead and introduce you to the agent-based models. These models are called agent-based models because we have agents in them. These individuals just live some simple life in computer most of the time. They live in my computer. I let them to have contact with others. If they're infectious, I'll let them to infect others, right? And individuals are sometimes protected by vaccination, sometimes they are not. And I look at the number of cases, I look at the number of deaths, I look at the hospitals, what would be the load on the hospitals. Here I'm showing a very, very simplified version of that, okay? In this virtual society, it's a well-connected society. On average, each individual has 15 contacts. These yellow dots are individuals, and on average, each one has 15 connections, okay? And I introduced the disease here. This person is infectious, okay? He or she was imported from outside, okay? Went to China, got the disease, nobody knows, and he came back and entered into our society where everybody is susceptible. Nobody has a disease before, okay? That's a problem with the COVID-19 because nobody had the immunity. Now, some people had immunity through vaccination or through getting the disease, but still quite many, large majority is susceptible. Okay, so if I let the disease run and these individuals will infect each other, they will recover. Some of them will die. The black ones are dead, and this kind of gray color, they are recovered. We have about 950 cases, 53 cases out of 1,000. If the society is well connected, lots of individuals you have in contact with, and the disease is quite infectious, it will infect almost everybody. Okay. All right. Now this is low isolation. What if I have high isolation? So better social distancing. Now individuals on average have 5 contacts because they try to limit their activities. They don't go to the AVMs or the stores. They only live in the household, and maybe they go to work, but they try to decrease the number of contacts they are having in a day. In this case, we have high isolation or better social distancing. On average, now everybody has 5 contacts, not 15, 5. What happens now? If I introduce the disease here, the virus will not find a way to infect others because there are not many people around me. So I won't have a chance to infect others. Total number of cases in this case is just 37. In the previous case, almost everybody was sick. Here, only 3.7% of the individuals were sick. So the social isolation, this is a very simplified version, but believe me, in essence, it's the same thing in real life. If you decrease contact, if you limit your contacts, your risk of getting the disease will decrease, okay? Okay, what if we have vaccination? Now, some of the individuals are vaccinated. Here, I think about 30% of the individuals are vaccinated, low vaccination, but still there's some vaccination. We are not even here yet as our COVID vaccination in our country. Still simple SRI model, and it's a well-connected society still. So the prevention of high isolation or the better social distancing is not observed here. So I have on average 15 contacts, but some individuals are protected because they are vaccinated. Okay. Now, if I let the disease go, disease will go, right? It will infect some individuals, right? But not as bad as the first case because some individuals are protected. If the virus is trying to infect others, right? But some individuals are protected because of vaccination. So the virus will find less individuals to infect, okay? That's why the total number of cases is about 55%. It's a little better. If I have more vaccination, and there's a critical value of vaccination, we're going to connect this to the how bad the disease is, called reproductive number, okay? If the vaccination is high, about 65% here, I think, still a high number of contacts, low isolation, right? But when I let the disease, the virus now will not find a way to infect because quite many people are protected around me, quite many people are vaccinated, okay? If I let the disease run in this scenario, only 37 cases, just like having high isolation, okay? Effectively, the vaccinating individuals is almost the same as putting a better social distancing among them, right? But the vaccination is better because they are protected for a longer time. For the social distancing, it might change if people are have fatigue for the prevention measures. They will not comply with the rules because if you apply a rule which is hard to apply for a long time, people get tired of it. It happens all the time. It happens everywhere, just like it's happening right now these days to our individuals in our country. They have COVID fatigue. They are tired of all these measures. Okay, that's why the compliance with the rules is might be decreasing. That might be another reason for the increase in the number of cases. Okay. I don't have much time, but the models I just show you, we don't call them toy models. Some people call toy models. Still, they are models. They are okay. They are just giving us an idea of what might be the real life, but they are not enough, because we have to calculate the hospitalization. We have to calculate the load on the hospitals. We have to calculate how good the prevention measures must be established, etc. Right? For this, we need more complicated models. I won't go into details, but this is one of the models I helped founding. It's called FRED. We developed this model in Pittsburgh, University of Pittsburgh. Here we use the synthetic population. So we have a synthetic population, an artificial population, but very much realistic, but artificial. Okay. We use pathogen parameters like how infectious the disease, the virus is, what's the incubation period, what's the latent period, etc. And what are the interventions that we're going to use? Is vaccination, antivirus, school closures, prevention behaviors, change in behaviors, etc. We also incorporate these into our model, and maybe most important, behavior change. Behavior change is the most important parameter in all models. If you change people's behavior, you can contain the disease. In parallel, you also have to work on the vaccination, you have to work on the antivirus, etc. But changing people's behavior is almost the most difficult problem and the most important. It has more effect on the outcome. Instead of a good vaccination, if you convince people, majority, to stay home, to apply the rules, to comply with the rules, you might have a better effect on you might have less cases. But of course, in time, you will need vaccination for sure. But it will give us some time to do this. Okay. I'll just show you one example. There was this big question: if we close everything for a short while, what happens? Before, we looked at just the schools. If you close the schools, because this was a discussion all the time during influenza pandemic. This is from influenza result, by the way, not COVID-19. Similar, it will be similar, but quite different disease. This is pandemic influenza. The reproduction number is about 1.7, so it's quite infectious. I'll tell you more about it. And whenever there is enough disease around, a number of cases, we close the schools. But people argue that, okay, if you just close the schools for a few weeks, that should be fine. It's very difficult to close schools in the United States. Not like Turkey. Just Minister of Education says, okay, we are closing. That's it. But in the United States, the states have their own governments. The federal government cannot tell them to close the schools. They have to decide by themselves, and not all of them will comply. So it's very difficult to close schools. They close schools only when there are firestorms. There's the snowstorms. Okay. So the question was, if we close the schools for 2 weeks, 3 weeks, 4 weeks, 6 weeks, can we contain the disease, right? This blue scenario is schools are not closed. Just everybody will continue their lives. This is the worst case scenario, okay? In this case, the attack rate at the end of the pandemic, at the end of the epidemic, how many people will be sick? 38% of your population will be sick. Or they will recover from it, but 38% in total will be the number of sick, the ratio of sick people, okay? And if you close the schools just for 1 week, it doesn't help a lot. You just drop this number from 38 to 38. So they are not different, okay? If you close schools for 2 weeks, then you start very little help here. 4 weeks, a little bit more. 6 weeks, 8 weeks. When you close schools for 8 weeks, then you see a more visible effect. But the problem is that you cannot close schools for this long. 8 weeks is too long, 2 months, not in the USA, no way. The problem with that is you close the schools, you let students stay home, but can you do that? They will go to other places. They will meet their friends. They will meet their classmates, etc. Right? In the shopping centers, shopping malls, in other places. Even if you close them all, right? Everybody will be home. But the disease will be progressing in the households, right? Especially in Turkey, larger households will have lots of members. We have lots of apartment buildings belong to one family. Even if you put really strict measures, they will visit each other. And this happened all the time. This is what happened in northeast region of Turkey. People just visited each other. They infected each other. This will go on in the households. And when you open, if there are no disease, if there are no cases, then you'll be okay. But there will be some cases. And those cases will start another epidemic, just like here. this orange curve. Another wave starts here. There is some discussion whether it's a wave or not, but there is another increase, right? Okay, when you remix people, for sure the disease will increase because you still have the cases, you still have the infectious people. All right, so we made some simulations for the public health policy people in California, in Pennsylvania. There is this big vaccine refusal these days, these years in the United States. Especially measles is very infectious. And if you don't have enough vaccinated people in the society, the measles can be quite deadly, especially in older people, and in even younger people, because the fever is too high in measles. They cannot really stand that. Is it going on? Yeah, okay. So if the coverage, the ratio of individuals who are vaccinated against measles is 80%, you think it's too high, it's not enough for measles. It's not enough for measles, okay? You will have lots of cases here. It has to be greater than some critical number. We can calculate this number. If it is 95%, the coverage, 95% of your kids are vaccinated. Only in that case, you can contain the disease. You don't have many cases, okay? So for measles, this is really bad. For COVID-19, it's not that bad. The critical ratio is about 60, 65, 70%. Based on the reproduction number, if you vaccinate individuals at this ratio or more, you can contain the disease. There are still going to be some little local epidemics, but they won't be too big. They won't be, system-wide big. Okay, and the same thing can be done for influenza in the United States. We can model the whole United States. It's very difficult. It takes a lot of time to simulate this, because here 320 million people are in this simulation. We can't even fit into our computers. We use the supercomputer. At that time, it had a huge memory, 1.5 terabyte. These days, it's not that high, but it was a huge thing. It was the highest in the United States. We can simulate our system in those machines, and it helps us to understand what would happen in the country level, like a big country like the United States. And we can calculate the effect of the measures. If you close the schools, what would happen? If you close the shopping malls, what would happen, etc. Right? But all these are based on some real data. We have to have the data, the cases, and how infectious they are, number of ratio of variants, how infectious the variants. All these parameters should be estimated properly, correctly, so that we can have a better or more realistic model. Okay. Let me just show you, and then I think I have to finish. This is a story. This is one of our projects called TICO project in Pittsburgh. 130 years of public health notifiable disease data have been collected. 130 years. Okay, this is for measles. Here, you are looking at the heat map, right? In this heat map, the rows are the states of United States, the states in each row, right? The columns are years. So x-axis is year or week actually, and the y-axis is the states, right? And the color, the third dimension, is the number of cases: high, the red, and low, blue. Okay. Now, measles is an interesting disease. It has cycles, annual cycles, multi-annual cycles. Each year it repeats itself. Right? In every few years, 2 years, 3 years, sometimes 4 or 5 years, it has more and more cases. Okay, so there is this signal, measles seasonality, and in every few years there is even more. Okay, this is what we observed in the data. But something happened in 1961. Something happened in 1961, and after that, in a few years, the cases dropped a lot. These days, we don't see many measles cases. What do you think happened in 1961? Any guess? Vaccination, yes. Thank you. All right, I think I should stop here. I added some extra slides here just in case questions, not much time to questions, but I think I should just go ahead and jump into, there are conclusions. Epidemic outbreaks and interventions can be modeled and simulated. That's what I'm trying to say here. Models can provide a framework to understand and forecast public health incidents and the assessment of the interventions, how good one intervention. So you have some money and you have to invest, right? You ask the question, which one gives you more money? Just like that. In public health policy, you just ask the same question. I have some resources. Where should I spend them? Should I spend them on keeping people home? Should I spend them creating new antivirals or vaccination, etc.? You have to really make this optimization, okay? And my maybe number one message, stay home when you are sick. I know it's not easy to say, it's easy to say, it's not easy to do it, especially people who are in need of working outside. These days we are hearing that some individuals fake their test results just to be able to work, but they are also putting other people in danger. They might be sick and they might be infecting other people anyway. And again, mask, washing hands, social distancing, and these days fresh air is also a very important factor in containing disease. Okay, I think I should stop here. So because I was told we have an hour, and thanks so much for your attention and time.
Thank you very much, Professor Güçlü. This was great. Some of the slides that you missed look very, very interesting.
Yeah, I know.
Hopefully we have to continue or ask questions and probe about that. So why don't we ask, are there any questions? Do I see the hands if there are raising hands, or you can just put it on the chat? We start a few questions in a question and answer session, and then go ahead. Alpay, Hocam, do you have a question?
Yeah, actually, instead of increasing the number of, very nice talk, by the way. Thank you very much for doing this. It was very timely and helpful for lots of people, especially who are interested in mathematical modeling. As a suggestion, rather than trying to increase the number of states for your models, concentrating on obtaining the coefficients in the model, like a better estimation of the coefficients in the model, wouldn't that be giving more accurate results? What do you think?
That's a good question. Maybe if you have a simple model, then your model will be successful as your parameters, the flow equation parameters are good. If you trust your parameters, then your model will be good. We have some problem in estimating some parameters. At the beginning of the pandemic, we were not really sure the infectiousness, how infectious this is. For influenza, I can just calculate an sigmoid function that if I'm infectious and some other person is susceptible, if I spend 5 minutes together without mask, then the probability of infection is 20%. If it is 10 minutes, it's 40%. If it is 15 minutes, it's 60%. We have those calculations, and we are we rely on those because they are coming from lots of data analysis. But for COVID-19, we did not have those data, so we have to. For a model, it's a big problem not to have good parameter. If my parameters have larger intervals, confidence intervals, then what we do is just we create a model, we run it many times, and then we look at the results. What would be the effect of those parameters? Just as a knob, we change those parameters and we try to see what's the effect of those in the overall outcome. We call this sensitivity analysis. It's also based on, if you have good parameters, then you are okay. When you increase the system, the number of compartments in your system, you will need more and more parameters. But nobody has, though if the parameter number is high, then probably you won't have good quality on those parameters. So we try, there's always this trade-off between the good quality parameters and the good model in terms of the number of compartments. We try to optimize that as well. We try not to make our models too complicated. We try to make our best to come up with better estimates for our parameters so that we will have a better model at the end.
Thank you.
I hope I answered it.
There is a request that you move one slide back. They want to see your the slide before that. Maybe the conclusion? Probably.
Was the conclusion?
Okay. Excellent. Yeah, maybe they want to just get the essence of the talk from
slide
that. They can. Okay, there's one more talk from Alberto Hoca. He's saying, maybe I can read him. He can also follow up, I guess, if he wants to. What happens if all the world decides to eat alone for 20 days and wear masks the rest of the time?
Good question. Yeah, then it might be possible. Seriously, if everybody can isolate themselves, but individuals, not families, individuals can isolate themselves, even in families, actually, if they can isolate themselves for 20 days, I think it should be okay. But the problem here is that this is a huge social contact network that people have contact with each other. What we do is we shatter this network into smaller parts. These parts should be small enough so the infection will go in those very, very small parts. And at the end, when we open the society, it won't be enough to start the new epidemic, right? But our problem in our, I shouldn't say a problem, it's a good thing as well. You know, I'm looking at this from an epidemiology point of view, but having large families is a good thing, right? Those apartment buildings were responsible for most of the infections. When our teams, the contact tracing teams, filiation teams went to the households, they said, oh, we are at home, we are not living home. But they live 6, 7 apartments in the same building. They are all relatives. They all visit each other. They don't consider this as isolation, okay? This is a big problem. But otherwise, very small families, 20 days eating alone, having masks, I think that it would be enough. We have to make some calculations, but my gut feeling that it would be enough.
There are raised hands. Start with Mohammed. Do you want to ask your question yourself? Go ahead. Unmute yourself and
yes, thank you very much, sir. I was actually typing it now, but since you mentioned it, I'll just say it as talking.
Okay, go ahead.
So first of all, thank you, Dr. Hasan, for the great talk. Thank you very much. I have a question regarding agent-based models because I'm currently working on one. Can you please explain how do you deal with the stochastic behavior of agent-based models, and if you can reference to some resources, because sometimes I do like multiple runs, even like up to 100 runs, and I run them again and I still get different results. So how can we deal with the statistics part in validation, sensitivity analysis, etc.?
Yeah.
And if one last request, if you can, if possible, somehow leave your contact information, because I might have questions.
Yeah, this is a tough crowd, Professor Güçlü. Go ahead.
Yeah. I usually have my email at the end, but I don't know why I forgot in this presentation. That's a very good question. That's a very difficult subject in agent-based models. Just like you said, it's stochastic nature will give you different results whenever you run it with the same parameters, right? There's a literature, there's new literature for the sensitivity analysis and other kinds of analysis looking at the interaction in the model. The model you are creating is also interacting with each other. So mathematically, you have to really understand this. Just making multiple realizations, multiple runs, and then looking at the results, especially if the system is close to critical area, statistically speaking, it's not going to be easy to get a picture. Because in those areas, just like the physical systems, when, for example, the water becomes solid, becomes ice, when you drop the temperature to 0, right? Around that time, everything is too correlated to each other. So the making averages will not help you a lot. First, you have to understand, are you in that region? If you are in that region, then there are different methods to deal with those, but it's a little bit difficult. Maybe later I can direct.
I think this is going to be a very technical discussion.
Yep.
For the details of agent.
Good question. Good question.
Yeah, interesting. I see Haluk Hoca has a question, and I see a question on the chat. Let's start with Haluk Hoca.
I'd like to thank you about the nice presentation. Couple of questions. The agent-based model is related to the network that underlying in the connections. So the question is then, how do you get that network? And how do you confirm or validate that this is really the social structure that we are living in?
Yeah.
And the second one is, once given the network, then you have the parameters to from susceptible to infected, that beta and that gamma. How do you choose those?
Okay,
and
thank you.
How do you verify that?
Yeah, good question. Second question is easier. For the at the beginning of the pandemic, it was really difficult for us to estimate those parameters. Then more and more results came based on the affiliation analysis, the contact tracing analysis, etc. Now we feel better in terms of our parameters for COVID-19, that B and G, etc. So the infectious period and the infectiousness of the virus itself, we have better estimates. And for the agent-based model, just like you said, it's a very good question. If you have an agent-based model, the population you are working on should have some structure. That structure might be coming from some well-defined network. It wouldn't be too realistic, but it will help a lot. For example, the small simulations I just showed you, the low isolation, low vaccination, etc. I used a spatial, a Euclidean graph there over critical period. So it's just helping me to create some very simplistically a society. But in real large-scale systems, we use the Turkish Statistical Institute data. We calculate the household size. We look at some very different statistics. We are actually, this is an ongoing project. We are looking at how many kilometers people go to work, where they work, the buildings' capacities, etc. Not all the statistics are available to us, but we try to come up, we try to gather as much as possible to create a synthetic population where I have some synthetic individuals living in a household with some family members, and then they have their neighbors, they have some interaction with the neighbors. Some of them students go to school. We know the school size, we know the locations of the schools. We gather the data from the Ministry of Education. We know where the schools are, the capacity, their class capacity, etc., where they are attracting students. If I don't know some specific data, I make it up. But I make it up in such a way that I consult the experts in that. Does this make sense? Because every modeler every modeler needs expert opinion. For the biology side, I talk to I talk to infectious disease specialists. For the school side, for example, I talk to education people. For many other angles, for many other facets of the problem, I talk to their experts. Because without expert opinion, the models has to stay toy models. Okay? So different parts of the data requires different disciplines, different expertise. We try to gather as much as we can. We try to come up with better estimates. And if we don't have an estimate for something, we make it up. But at the end, when we run many times, we will also look at the behavior, how we fix some windows. What happens if I change the parameter in this window? What would be the effect on the outcome? Based on these, we try to rank the variables. If those variables with much higher confidence intervals are at the top, when we invest more to get better estimates for those parameters, especially. I'm hoping I answered. Not maybe perfect.
Thank you very much. I mean, this is an important topic that Haluk Hoca has brought up. There is a question on the chat which stated, probably I know the answer to that, but did you take the reinfections into account? Because after you recover, you can reinfect it maybe 3-6 months later. Is this a significant problem for COVID, or did you ever?
It is. There are some studies that look at that the reinfection time, how long is it? There are many studies that if you had the disease, the reinfection will not happen before 6 months. There's a new study before 8 months. For vaccination, we have some similar stories, but as a modeler, I have to include reinfection because I know that the virus is not one anymore. We have many viruses. They are competing with each other. And the protection for one of them you had, if it is 80%, 90%, for the other one, the protection will be 50%, 40%. So I have to, recently, we are taking these into account. Reinfection is a problem. Still, it's not that at, very fearful proportions, but it's there. For many other cousins of coronavirus, it's the same thing. The virus changes its genetics a little bit. It comes back, and then your body doesn't recognize it well. You might get sick, right? Reinfection is happening, still not at the very bad proportions, but our models have recently these days we have been taken into account. We have to. Otherwise it wouldn't be realistic.
I don't see any talks or raised hands, if I'm not mistaken. I hope I haven't missed any questions in the chat either. There's lots of thank you notes, and thank you for this very many thank you notes on the chat. The official hour is over, but let's continue a little bit more on the questions if you have time, and then we will maybe even chat informally once we finish the YouTube chat. I don't know whether you had another talk, right?
I had another talk today.
When was that? It is, you want to advertise?
My talk is at 5, but the conference, the European Biomedical Society conference, will start at I think 2, or already started.
Oh, I see.
But I can say some more. Yeah.
You probably want to join the conference that you are invited.
No, that's okay. I can spend some time here. No,
excellent. Munzer, you have a question?
Yeah. So, of course, thank you very much for the very interesting presentation. Second, I have a question about the system dynamics model, SIR model. So I tried before to use the very simple SIR model, and it was based on actually a course I took with Cengiz Hoca, modeling of biological systems, before 3 years ago. But it's, it's a very simplistic model, and I wanted to include the quarantined, isolated, exposed compartments, but we don't have data for that. And I don't know if we can acquire data for that. So how can we?
For COVID-19, we have the data.
For exposed people?
Yeah, we have data.
So it's not only for susceptible and infected and.
We have data. I mean, these days, at the beginning, in the first 3 months, 6 months, this was very problematic. Most of the modeling studies, modeling papers, 95% of them are just rubbish. Nothing. It doesn't make any sense because they use wrongly estimated parameters. But right now, we have better estimates for all kinds of complex models you can come up with. We have the exposed parameters. We have the quarantine parameters. Quarantine parameters are not biological, are mostly, the country-specific or the region-specific. And hospitalization, etc. We have data as well. For Turkey, we don't have everything. We have some, but if I don't have data from my government, I look for data from some other governments if they are publishing their data. This might also be a solution, maybe a temporary solution to that.
Yeah, but that was I'm interested in cases in Turkey. So, for example, if people are getting infected with coronavirus, but they are just staying at home, they are not reporting themselves to the government, maybe. So, how can I estimate that in Turkey, maybe? Is there any mathematical way for that?
Yeah, not mathematically, maybe, but you have to dig into the literature. Studies are being published, not as much as we want because the data is scarce. But some other fields have some better estimates, or some, the survey results, etc. Based on those, you can come up with better parameters. It's better than nothing. If you don't have the exact data, you have to really find a way to estimate it. Reasonable estimates for it. You have to look for not only the literature in the modeling literature, but also other literature as well. Economy, for example. There are lots of papers from economy departments dealing with similar problems. They're also good modelers, by the way.
Okay.
So there are, you have to model or assume. If you take a lecture from me, that can only take you so far, right? You have to build on.
It's a good start. It's a good start. That's what I was trying to do with this talk. Just create an interest in you that the models, and I'm sure you already have some experience, but the modeling and simulation can really open some new doors, can help us understand. It's like the flashlight. It doesn't really enlighten everything, but it might give us an idea where I'm going or where I might be going.
Okay.
That's the whole idea.
Thank you, Munzer.
Okay.
You had an additional question?
Yeah, if that's okay.
No, go ahead. If it's brief.
Okay, very quick. So I noticed that all the models are closed models. We don't have compartments for people entering and exiting the country. Is that important here, or we can ignore?
That's important. But that's difficult. But we have those models as well in literature, because there are some countries now who are COVID-free, but they cannot stay COVID-free for a long time because constant influx of people coming into those countries. So there are some new studies looking at that as well. If you have the data, if you have the parameters, it's kind of possible. on a not realistic, but educational way, I can create those parameters. I can just feed the system with new infected individuals, so my number is increasing. We had those models. We had lots of them for influenza. For COVID-19, it's still new, but there are some in literature. medRxiv. First, try medRxiv. You will find lots of things there.
Do we really know the current infection fatality ratio for Turkey?
That's a question for me, right?
Yes.
Okay. So in our country, we made a list of countries in which at least 5,000 people lost their lives. There are 45 of them in the world. We are ranked 44. We are before Israel.
Okay.
Our mortality rate is too low. It's about 1%. That's not real. Everybody knows that. Even government knows that. Because the way to, it's at the beginning of the pandemic, people said the number of cases is not reliable because it's based on tests. If you don't do enough tests, then the results will not be reliable. So we won't be using the cases. Instead, we'll be using the number of deaths, which is more reliable.
Yeah, that's what I thought.
Turned out it wasn't that reliable as well. I mean, it's not the same. You are not counting the same thing. For example, if an individual comes to a hospital in Turkey, PCR test is negative. That means that then he or she is considered not a case. But the problem in the lungs, just the test was negative. They don't do the test again. They consider this as a person with COVID-19, not officially. She's been taken care of at the hospitals. But he or she is not in the statistics, and that person, if that occurs, that person is not counted in the number of deaths.
Okay.
The average is about 1.9, 2%, 1.8%, 2.1% in the world. In our country, it's 1%. So I think it's safe to assume that the number of COVID-19 related deaths is about twice more, maybe a little bit more.
I see. So you're thinking that it is underestimation of the deaths.
Sure, yeah.
Or maybe
even members of the science board, accept this.
Okay, so that means the overall that also changes a lot with the age, right?
Right. Oh, yeah, a lot.
A lot with the age. So I mean, for let's say the population that's watching, the young generation among us, their actual infection fatality ratio is much lower than us faculty members, I presume. Right?
Yeah, right.
So that's also an interesting.
After 55, it increases a lot.
Okay.
Considerably increases after 55. 65, 75, 85 goes to 35%. So 1/3 of the cases die if the patient is over 80 or 85 years old.
So, I mean, I'm assuming, thank you for this great inspirational talk. We will have probably ask a question, then don't give the answer, and then stop the presentation. Then we will.
I would have finished my presentation.
Why don't you get rid of the share screen view? Are there any things that you want to show? No, probably not.
No, I mean, we won't have time. I don't want to spend too much time.
It's okay. There will be some left for the follow-up seminar.
Sure. Yeah, I'd love to.
You don't have to. So the question is, so I'm assuming we have now the data collecting everywhere locally in municipalities, and I'm assuming that policymakers, getting lots of these models from you and some additional people, fight against the models, and they have much more complex models linking these to, I don't know, economic output, some additional social measures, and then they make our policies, right? In Turkey, that's how it is?
Oh, in Turkey. Well, I thought you were talking about the ideal. Yeah, I worked for BARDA in the United States, this body under Minister of Health, Department of Health and Human Services, responsible for buying the vaccine, vaccine. They are the body which spends the money on it. And I made lots of models. We made, as a group, made lots of models for them. In Turkey, the culture, the political culture is a little bit different. We have a science board that was formed at the beginning of the pandemic. It was a good thing, but I mean, something unacceptable happened because the chair of the board is the Minister of Health. That doesn't make any sense. This body is supposed to give up, supposed to you know, come up with methods, come up with policies,
recommendations.
Apply. But the head of this committee, the board, is Minister of Health himself. It's not a good mix. I don't think so.
No,
but anyway, still, I mean, and another problem is, I say this in different places. Most of the board members are infectious disease specialists. A pandemic or any public health problem. I heard this from the one of the older directors of public health of Istanbul as a district. The public health is a very serious business. Only doctors, MDs cannot really handle it. No way, no way. But in our board, we have only infectious disease specialists. Later, they realized this and they said, okay, let's have another board, you know, social sciences board, Toplum Bilimleri Kurulu. But this was a defunct thing, just made a few meetings and that's it. These days, we need them more. These days, people starting, you know, having suspicious about the vaccine. It's a big problem. I think we're going to suffer from this. Right now, we need that board or whatever this board is supposed to do that come up with, you know, ways to understand people or to help them understand better. If you look at the social media, oh, it's a very different story. So
I think before we go any further in very troubled waters,
I'll talk about this in this afternoon.
And yeah, that's is this going to be a conference will require registration or will they?
I'm not sure. This is Biometric Society. I'll check. I'll send you the link.
Okay, please, if we can watch, that would be interesting. We will post it next to your talk and says if go ahead, look for an ideal scenario where actually policymakers listen to.
Yeah. This is not specific to our country. I mean, this is a very complex problem itself.
Right.
It's not easy really to manage a pandemic, and different cultures have deal with differently. I mean, it's different in the United States, different in Italy, in Spain, in United Kingdom. It's different in our countries because you know our culture is different. Our way of looking at the politicians or looking at the government is different. So everybody has their own experience and quite different.
Thank you. I guess this is also very humbling experience for everybody. I mean, including the scientists and also the policymakers. The politicians, they always think that they can control everything, right? They can they can get few ideas, few preventive measures, and they think they can control everything and they can control the pandemic in a couple of months and they're going to open everything. They like to give promises, but I mean, then the truth comes in a couple of months. I mean, some things you can control, some things you cannot control. I mean, therefore,
there is also a psychology here. You have to, you know, you have to give hope.
Yes, maybe that's hot.
Even when the hope is little, you have to give hope because the hope will help them to comply with the measures. Will help them will help them to wear face masks. Will observe social distancing. This is very important. Just like a football game. The technical director, the trainer, is not there just for the technical stuff. He's also she is there just to encourage people.
Right.
You can do this because when you really encourage people and if they believe in it, they can do it. We know that. This is not false hope because it's based on some hope, but it should be given. And we have hope. Just if you do this properly, we can manage this.
I see.
These days, vaccine refusals, vaccine hesitators is actually concerning me a lot. It's a big problem.
I mean, it all seems to be also a big problem in Turkey.
Yeah.
Apparently, it's sometimes even from social media we are seeing it.
Yeah, if you look at social media, everything is polarized. You see a bad picture all the time.
Thank you.
Yeah, people on the street doesn't care that much, but social media, especially I'm used to Twitter. I don't know any other social media. Twitter is sometimes hell.
Yes, the Twitter world is something else. I don't know.
Yeah.
that's maybe we should utilize that somehow during the models.
Yeah, that's one of my research projects supported by the European Union. I'm using the Twitter data to come up with better strategies. We have been collecting tweets since March, early March, even late February. We collected about 250 million tweets about COVID.
I see.
It's very difficult to analyze. It's huge data set, huge. So I need some help in that.
This turned into a dialogue. I don't see any.
Sorry about that.
Question. It's fine. I think fine. I don't see any question. There is a question saying that do you think all the medical methods have been explored so far? That's a very general question, I guess.
Excessively.
Yeah, everything has been explored. Maybe
at the beginning, I remember one of our faculty members. He died, and this was in March. We did not know what to do. Seriously, I mean, we used at least 24 different drugs, and he said, "Yeah, use all the drugs on me. I'm fine. I'll be fine." I'm
sorry to
These
hear.
days we have a better strategy now. We know, but it's not easy sometimes to change things. Still, we are giving this medication that doesn't do any good.
Right. Yeah, I know which one you mean.
I think it's changed. It's going to change, but it's not easy to change.
It's still in the books, official books, but nobody is recommending or using.
It's not updated yet. Yeah.
I see.
Yep.
Thank you, Professor Güçlü, for this.
Sure.
I think we can continue for a while. I think maybe we'll take another promise from you that you will come and visit us and we give us a little bit more time in a better time to talk about this.
Face to face, inshallah.
Face to face, yes, definitely. We are not that far. Kandilli Medeniyet University is just a stop.
Close. You are even closer to my home. I live in Beykoz.
Oh, really? Okay. Please come and visit us on better times, hopefully.
Sure.
I'm sorry we kept you away from your...
no problem. No, it's okay.
Thank you. Thank you very much.
Thank you.
Let's stay here for a while, but let's close the YouTube. Bye-bye. So we will go over there.